All right, I'm just going to give everybody an opportunity to join the room here. I'm going to share my screen for a second. All right, well, thank you everyone for joining our third Stroke Month webinar. We're so excited to have Jessie back to present again. But before we begin, I just want to express my thanks and just really gratitude for all of our EMS workers out there. This is EMS week, so it's kind of a thankless job sometimes, and just know that we do think about you. And boy, you're some of the most resilient people. You do so much with sometimes so little resources. So thank you for all you do. And you must do it because you love the job. So again, thank you for joining. And just our quick disclaimer that the opinions expressed in this webinar are solely those of the presenter and may not necessarily reflect the American Heart Association's official positions. This webinar is intended for educational purposes and do not replace independent professional judgment. The AHA does not endorse any product or device. And like I mentioned, we are so grateful to have Jessie back here. Not only is she a fantastic volunteer for Mission Lifeline Stroke South Dakota, but she is an amazing stroke coordinator. I think her title at Sanford is stroke specialist. And with that, Jessie, I'm going to pass it over to you.
Perfect. Thank you so much, Joni. Let me see if I can get my slideshow shared here. All right. Whoa. Can you guys see my screen okay? Perfect. Well, thank you again for having me. Also, Joni. Like she said, my name is Jessie Wolf. I'm the Stanford Medical Center stroke coordinator. We'll talk about some stroke and EMS today. I too have disclaimers. And I put a picture of our stroke medical director on here because he's my biggest disclaimer. I stole some of these slides from him, so I apologize in advance. Picture's kind of funny. He's sitting in our epileptology monitoring unit, and you can see around the computer it says, "Do not sit here. This is for the EMS nurses, EMS computer," or "Do not sit here." And he's sitting there pointing at it and laughing. So we bend the rules a little bit sometimes, and you'll see some of that in his slides. Other disclaimers: I'm hospital based. I've never worked on EMS, but I'm so jealous of you that do. And then I'm a huge neuro nerd. I get way too excited during presentations, and I'm likely over caffeinated and like to slur my speech. So kicking it off, why pre-hospital assessment matters with stroke. Stroke is a super time sensitive emergency. Time is brain, if you've never heard that mantra. Every hour of stroke, those brain cells die from lack of blood flow and can cause a big impact on that patient's life. Pre-hospital personnel are the first line of care, so they're the most important. Accurate and early recognition can reduce stroke treatment delays, and enabling early activation of stroke teams and transport are appropriate with our stroke care. Initial patient assessment. So of course, a patient would call 911 with their stroke symptoms. They all absolutely call 911. We hope they do. Ensure scene safety, perform standard precautions, rapid assessment of those ABCs, airway, breathing, circulation, determine that patient responsiveness. I actually had to Google AVPU scale, if that's often used, the scale of their alertness, verbalization, pain, and responsiveness. Obtaining vitals, which are super important on the incoming report, what that blood pressure is doing, what their oxygen saturations are, the initial blood sugar or glucose, a finger stick glucose, and oxygenation, making sure they're over 94% SATs or oxygen as needed. Big part of this presentation will be talking about stroke recognition and severity tools. What's the difference? You've all heard symptoms of stroke, fast, be fast, all these different tools, but they're used to recognize the stroke and then tell how severe that stroke will be or what type of treatment that stroke can have. So recognition tools are also taught to the general public. We want them to call 911 when they notice these strokes. It's used in EMS for, so we're all kind of speaking the same language, the patient, the EMS, and the pre-hospital staff. Other recognition tools, Cincinnati, FAST, Be Fast. We'll talk about Be Fast probably the most in the next coming slides. Severity school tools, excuse me, is a predictor of how severe that stroke's going to be, and also a predictor of a large vessel occlusion. So a stroke needing thrombectomy care or clot retrieval. NIHSS is used by nursing staff in the hospital. MINS and stroke ban is what we'll talk about during this presentation. So Be Fast, we'll break it down per each letter. The B in Be Fast, think of balance, balance issues, dizziness. Sometimes that patient's severely nausea and vomiting with all this balance and dizziness. E is eyes, think vision loss, excuse me, vision loss, doubled vision, blurred vision. I use Dr. Sandu as a lot as a source when I say, when he says eyes deviated, he says that's my buzzword. When we have weakness and eyes are deviated, that means stroke until proven otherwise. So you can see in the fancy picture at the top, it's talking about NIH gaze. That patient, a normal patient would be able to track back and forth with their eyes. So if you come into that patient and they're only looking one way, ignoring that left side, maybe they're staring off to the right and tracking a little bit over there, but they can't overcome midline and look left. A lot of times that is definitely a huge neural problem, stroke being number one on the list. I did sneak some of the NIH stuff in here per request of a couple nursing staff. So eye deviation, when we test this in the hospital, we'd have them follow with their gaze all the way to the right and left. So have that patient follow finger and back again. NIH score is the stroke score nursing staff would use on arrival to the hospital. 0 is that patient can track side to side. 1 is gaze preference. So they're clearly looking at one side, but maybe they can come to midline. And forced deviation means that that patient's eyes are almost buried to one side of their vision fields and they can't track at all to the other way. F and Be Fast, facial palsy, facial weakness, facial droop. To test this, sometimes like the picture of the gal here, you can see clearly there's a facial droop. Sometimes you have to have them smile, show me your teeth for less severe facial droops. So you look at, also when you're looking at this a little closer, look at the upper and lower facial features. You can see eye drooping, etc. at times. They'd score a 0 in the NIH if their smile is symmetrical. The A in Be Fast, arm weakness. I always say arm and think about the legs too. The acronym clues you into arm, but leg weakness is just a big of emergency too. Arm weakness, the best way to test it is like you can see in the little lady wearing the purple shirt, the one on the right, she's holding her arms out, palms up, straight out like you're holding a heavy tray. And having them close their eyes is a big indicator. You can see subtle weaknesses when they close their eyes. So maybe her arms are equal until she closes her eyes, and then you can see her right arm is drifting down or weaker. So to test arm weakness, have them hold their arms up, palms up, hold it for 10 seconds, close your eyes, and see if it's just slightly weak or very, very weak. Maybe they can't even lift those arms up. S is speech change. Speech has a lot of components to it. Slurred speech, loss of speech. Sometimes this can be also confused with confusion. But when we're thinking stroke and speech, we want to talk about speech articulation. So clear speech, naming objects, and following commands is also part of that speech center. So patient might have dysarthria, really slurred speech. To test this, say, have a command. Some of ours, whatever phrase is easy, we say it's a sunny day in Sioux Falls and listen for that slurring and can they follow that command? Naming is really important. And sometimes these patients, you know, they're frustrated. You're asking questions. Who are you? When's your date of birth? And they can't spit those words out, but you can tell they're thinking them. Naming goes along with expressive aphasia. Have them name objects. And when you don't have the nice NIH stroke scale pictures right in front of them, you can use what you have, a watch, a knuckle, a wrist. Sometimes glasses are really easy to spit out, but knuckle and wrist aren't used in daily conversation. It's easy to test for those without pictures in front of you. And receptive aphasia, having them follow commands. We had the patient lift up their arms and did that already, but have them show me 2 fingers, sometimes 2 fingers on your left hand, and see if they can process that information and follow commands. And the T in BFAST is time. We tell our patient population, stroke is emergency, call 911 now. But think of T in the EMS community of when did this start? What time did this start? Think of the last known normal and onset of symptoms. When was the patient seen without symptoms, and when did they start? And I have a slide on that coming up, so we'll dig a little deeper into that. So BFAST is stroke recognition. Large vessel occlusion recognition, or stroke VAN, is another very easy assessment to do. Large vessel occlusion is when the patient's having an ischemic stroke and they throw a clot into a large vessel within the brain. So you can see on the skeleton here, the internal carotid artery, M1, M2 segments are those big fat arteries leading up into the brain before they start branching off into smaller ones. In the posterior part of the brain, the vertebral arteries join to the basilar, so that's a large vessel that branches off. Those are all vessels that if you threw a clot there, you could be potentially a thrombectomy candidate. I like to tell a lot of staff, if you have a large vessel occlusion, they're going to have lots of really black and white symptoms of stroke. It's not going to be the subtle subjective numbness and tingling. They're going to have more than one symptom, and they're going to be pretty pronounced. So to screen for stroke VAN, think of the word stroke and any focal weaknesses. So all weakness in the arm, face, or leg, arm or leg are the big ones out of there. So one side of the body has weakness. And then think of the word VAN, V is that vision, gaze deviation, vision field cuts, double vision, or blindness. We kind of assess this with the E and BFAST already, but that gaze deviation is really what we're looking for. A, think of aphasia, inability to speak or understand, that's very pronounced. And N is neglect, ignoring one side of the body. So when your eyes are gazed one way, that patient's likely ignoring the other side of the body as well. Terminology when we're talking about stroke VAN, we use stroke VAN positive or stroke VAN negative, indicating that the assessment was positive for findings or negative for findings. This has an 82%-ish success rate in detecting large vessel occlusion. And this is important for a lot of EMS services. And then looking to the future of South Dakota, how we look at large vessel occlusion. So if I was in California and I was 2 miles from a hospital that could do interventions and 2 miles from a hospital that couldn't, doing a stroke VAN assessment guides those hospitals or the EMS crew where to take that patient. If it's stroke VAN positive, I would take them somewhere without stopping to that closest thrombectomy capable hospital where they can do thrombectomies. So I said we talk about last known well and onset of symptoms, such an important piece of the puzzle and so confusing. And sometimes the time changes on these patients depending on what questions we ask them. So we ask them these questions to sort out treatment options based on when it started and when they were last known well without symptoms. At Stanford, I know we give 2 questions. Our doctor will ask the 2 questions. When was the last one well? When was the onset of symptoms? He wants to know 2 times if they're not the same. So onset can be witnessed, can be unknown. We always ask for a witnessed onset. Not that we don't trust our patients, but we want to know exactly what was going on. So we always further question. If somebody says the onset was at 8 o'clock, we'll say, was it witnessed? Who are you with? Were you by yourself? An example of this, patient waking up and noticing symptoms of stroke, slurred speech, right arm weakness at 8 o'clock. So the patient calls 911 and said, I had a stroke that started at 8 o'clock. Our EMS crew would ask, you're having a slurred speech now, but did you speak to anybody before 8 o'clock? And did you use that arm prior to 8 o'clock? Sometimes the patients think about it a little bit. They're like, no, my alarm went off. I rolled over to my side and I tried to shut off my alarm with my right arm, but it was clumsy and weak and I couldn't do it. So I turned over and told my wife and my speech was funny. So technically I woke with those symptoms. But we do have those patients that say, yes, I got up, my alarm went off at 8. I shut it off with my hand that was working fine, told my wife good morning, went into the bathroom, and then I had symptoms at 8:01. Um, Always ask the patient, what time did you wake up for the day? Has this ever happened before, for other clarifying questions. Last known well is the last witnessed time that patient was noticed without stroke symptoms. So the patient that woke with symptoms of stroke, did they go to bed okay? Did the family talk to them before they went to bed at 10 o'clock last night? Etc. It's also important to remember that we do have wake up stroke treatments. Back a long time ago, we used to say, after 3 hours, there's not much to do for that stroke. Now our window opens up to 24 hours, helping with those wake up strokes. So we definitely want to know what time you went to bed last night, because if you went to bed at 10, woke up at 8, you're still within 24 hours of, and there could be potential treatments for you out there. So it feels like a lot of times when we further question these patients, we get more answers. So the more questions, the better. Other history to gather, of course, the symptoms. Were they BFAST? Did they have any of those symptoms? Stroke band symptoms. Again, the last known well is so important. And the exact time of onset, and was it witnessed? If a family who witnessed it could provide collateral history or even accompany the patient as best practice, we want them, because we'll have more questions than you think to answer when that patient comes in the emergency department. So witness to either be available by phone or come with the patient. Past medical history that's important with stroke, prior stroke, history of high blood pressure, diabetes, AFib, seizures and complex migraines, which we'll talk about stroke mimics later too. But if a patient has a lot of neurohistory, it could cloud a stroke diagnosis as well. What home medications they're on, antiplatelet medications like aspirin and Plavix, or aspirin's an antithrombotic, but Plavix, Brilinta, etc., and anticoagulants, blood thinners, warfarin, Eliquis, Xarelto, etc. Best practice, again, bring those meds with. When we're talking about anticoagulants and the patient taking them, a really important question is, when did you take this last? We oftentimes see the patient needs to hold that blood thinning medicine. Maybe they have a big surgical procedure that was planned for today. So the doctor told them to hold that med for so long. So they're on Xarelto, but they took it maybe 5 days ago in prep for a procedure. That's important to know too. And then have they ever had seizure, trauma, or any similar symptoms in the past is an important question too. Stroke mimics. I feel like this poor minion a lot sometimes. Patient, I always say neuro's a little gray. I'm jealous of the cardiology world where you can do an EKG and see in black and white what's going on. And we have to go off of symptoms and some subjective data sometimes. So best rule of thumb that we say at Sanford is stroke is a time-related disease. Think stroke as your top priority, and then we can rule out the rest as we go with that workup. But you can't go back in time to treat a stroke if you don't think of that as your number one priority. A lot of these mimics can also be ruled out with some patient history and a simple CT scan. The number one mimic of stroke or stroke-like symptoms is hypoglycemia. So blood sugar being low can cause slurred speech, some sensation changes, even some weakness and confusion. Migraine history, and seizures. There's a phenomenon called Todd's paralysis. So when the patient's having an active seizure, that part of the brain relaxes after the seizure activity and shuts down, causing weaknesses and stroke-like symptoms. Psych and panic attack, subdural hematoma, tumor, those can be potentially visible on a CT scan. Syncope and cardiac difficulty, blood not getting to the brain like it should, encephalopathy. So again, I put it in bullets on here. Always think stroke until we can rule out some mimics along the way. Everybody has always been like, I don't want to treat a mimic with a stroke treatment if it's going to be a mimic. There's and some of the data behind that is if a patient comes in within the thrombolytic window and I give them a thrombolytic and it ends up being a mimic, maybe a migraine that we weren't sure of, the headache hadn't started yet, they're having an aura, the risk of them bleeding from that TNK is less So 1 in 200, and compared to that 1 in 5 to 6 with a true ischemic stroke. So less harm to the patient. And about 7% of acute ischemic strokes treated with lytics are actually a stroke mimic in aggressive hospitals. So you'll see that every once in a while too, that it looked like a stroke coming in, treated it, and ended up being something else. Kind of shifting back into EMS mode, I get off on tangents, I apologize. Again, pre-notification and transport. Pre-notification is the biggest #1 best practice for stroke care. Notifying the receiving hospital, stroke center, etc., ASAP with that stroke alert. So after picking the patient up, notifying that hospital that you're taking that patient to that I have a stroke coming in. This allows the hospital to grab their crew and get them together to meet that patient in the emergency department. Sharing the last known well, your stroke scale score, whichever one you use, BFAST, stroke fan, vitals, and other relevant findings also helps them prepare. If a patient coming in with blood pressure through the roof, we might be already setting up IV push meds or drips to give that patient for their stroke. And then follow your regional stroke triage protocols. Example, which hospital to take that patient to. I gave an example of a while ago of a hospital that didn't have a CT scan. Taking a patient to a very rural hospital without a CT scanner would not be helpful. You have to, and when there's a hospital a mile away with a CT scanner, you'd go there first for a stroke. So thinking about things like that. Differentiating is still not coming out right. Differences between stroke types and blood pressure management. Ischemic stroke versus hemorrhagic stroke. Knowing EMS crew are taking that patient in for a CT scan and we don't know what type of stroke that patient's having, they can look very similar. That CT is the key. I like to be a huge stroke nerd, like I talked about, that you can almost predict what that patient's looking like. And where we'll treat their blood pressure. Ischemic stroke is much more common. It's about 80 to 85% of all strokes. They're often found with those focal deficits. So BFAST symptoms can be subtle and subjective to very severe, and they may be eligible for thrombolysis or thrombectomy. So tenecteplase, TNK, or the clot grabbing procedure to take that clot out. That'd be the 2 treatments for ischemic stroke. Hemorrhagic stroke is another beast in itself. They can present with any of those BFAST symptoms. They can even have stroke van symptoms. But the big key to them is they have symptoms of stroke, and they can also be accompanied by that headache, usually a severe headache. Nausea, vomiting, and altered mental status is very common in those hemorrhagic strokes, in addition to their BFAST and stroke van symptoms. The key to them is when we get them into CT, see the blood on the CT, we drive that blood pressure down right away. That high blood pressure is so severe on these patients, such a bad complication for them. Typically, too, with the hemorrhagic strokes, all blood pressures will typically be high, but the hemorrhagics are really, really high usually. So that CT will tell us what we're doing for blood pressure management. If we're having an ischemic stroke and not able to give lytics, we let that blood pressure be a little high, not treating unless it's greater than 220/120. And sometimes your eyes get a little bit big when you see that, blood pressure is 200/100. That's okay for those ischemic stroke patients. Ischemic strokes that are a candidate for lytics or TNK, lowering that blood pressure less than 185/110. And again, when that patient is in the CT scanner and we see the hemorrhagic stroke, we target that blood pressure down 130 to 160 range-ish on them. So blood pressure is very different in all those patients. And then hospital destination considerations. I touched on this just a point, but the state of South Dakota is a little different, as we are so rural and so sparse that we actually only have 3 types of stroke centers in the whole state. Comprehensive Stroke Center is our CSC, is where that hospital can do 24/7 thrombectomy, has neurocritical care, advanced imaging. A step down below that is a thrombectomy capable center, which has 24/7 thrombectomy, but no technical neuro ICU, and technically should be sending bleeds to a center with a neuro ICU. A primary stroke center is a center that can treat with IV thrombolysis or TNK, but unable to have mechanical thrombectomy 24/7. And acute stroke ready hospitals are those small rural hospitals that have a CT scanner and lytic in their pharmacy that they can treat that patient, stabilize them, and transfer. There's limited interventions they can do. So I stole this from Dr. Sandu. This race cat trial suggests this is a trial that was done in bigger states with lots of comprehensive stroke centers and lots of thrombectomy centers, lots of primary stroke centers. It's talking about direct transfer to that comprehensive stroke center for severe strokes can reduce their California hospitals might skip that one hospital without the CT scanner and go right to a comprehensive stroke, even if the transport time is a little bit longer to get that patient advanced care. EMS protocols and implications. Of course, this is what we're looking for in the long range with South Dakota Stroke Care, but how do we use these stroke recognition tools and how will that help triage our care? And then how it fits into our South Dakota picture. So a quick summary, like I said, I talk way too fast for an hour presentation, but summary, early recognition of stroke and triage are critical in stroke care. So that BFAST and stroke VAN scores, focus assessments of those ABCs, glucose and history, using standardized scales to improve communication to help decision make on those patients. Again, recognizing large vessel occlusions with that stroke VAN and applying appropriate scales, knowing blood pressure targets and historical red flags to stroke and stroke treatment. And then pre-notification, again, improves outcomes for those patients. So I really cruised through that. I should have told you guys if I'm running too fast, stop me. I get in my own world and just talk away. But are there any questions or comments that I can answer?
Yeah, thanks, Jessie. I do have one question, and that is, sometimes in rural states, and I think this is actually more of a nationwide issue when it comes to like a thrombolytic checklist. s- Um, oftentimes it's just repeated or done in the hospital, but are there some specific or important parts of that, a rural EMS in South Dakota should be aware of, or what's the most helpful things to ask, at least to get the patient or the patient's family kind of thinking about that as they get to the hospital?
Yeah, good question, Joni. Thank you. So kind of with what we've taught local EMS and have opportunity to teach more is always say, you could be a candidate for this procedure, a clot retrieval procedure, that not everybody coming in is going to get that procedure is kind of one of our biggest educations that please don't say you're absolutely going to get this, but you're a candidate for it is one of our biggest teaching points. And then to move that patient through quickly, so EMS would bring the patient in. Our best practice is if that patient's able and stable, that they can go straight to CT, which is located very near the EMS bay, do the CTA imaging, find that large clot. Patient needs 2 IVs. So that could be something if it's a long transfer in, making sure they have at least 1 IV, 2 would be best practice. And then removing the patient's clothes, knowing if we go to thrombectomy on this patient, we're going to go possibly radial, but most likely groin. So taking off their clothes and having them prep just saves that minutes. When you know that, this patient's gonna come in kind of hot, that we could do that on the route in, but the 2 IVs is huge, and the blood sugar check is huge too.
Yeah, that's great. I think it's so impressive in South Dakota that you have telemedicine in motion and
Yes.
have access to telemed in the ambulance service. And have you seen that used a lot with your stroke patients?
And I don't have that experience, but I'm so, you read about larger systems of care in other states and having, we do have that available in South Dakota too, and then also having imaging, like seeing that patient and doing the assessment the video is worth a million points. You can see so much more when you're versed in what you're watching. And then larger systems of care also kind of jump ahead of us that they have a CT in their EMS rig. So maybe the future of EMS in South Dakota will get there eventually. I hope we do, but it's just it's becoming so streamlined, and we're watching those best practices from other states.
Yeah, I think South Dakota's ahead of the game with having that telehealth available
Yes,
within EMS. So that's an awesome resource to help get that patient to definitive care faster, or at least help
yes,
with that stroke diagnosis or suspicion. Yeah,
yes, yes.
yeah, I see we have a question that came in here. Um, what do you consider stable to send to CT first?
I'd say airway stable is the number one. Like if the patient's nausea, vomiting, unable to lay flat for that CT. So airway stability is the number one. And then if that blood pressure's technically, we don't want it too low. So if the blood pressure is tanking out 90s and better is good. But if blood pressure is 60 and unstable airway, we would room them first and then stabilize the airway and then go to CT.
Great. All right. Do we have any additional questions? Okay. Hey, well, this was so. Oh, Carrie Mastler has her hand raised. Okay, Carrie, I learned in our previous webinar how to get you off mute. So hold on just a second here. All right. You should be able to ask your question or make a comment, Carrie.
Can you hear me?
Yeah.
Okay. Do you recommend sedation for a patient who will not lay still for you in the CT scanner when you're suspecting a stroke?
That's an excellent question that can be answered one of two ways. So if you hear my answer and somebody answers it a different way, take it with a grain of salt. Plain head CT takes 2 minutes. So I know trying not to sedate those patients is best practice, but knowing that, they're climbing off the CT bed, a little whiff of Ativan might be helpful for that patient, but knowing what their assessment looked like before they got on the CT bay, that if they're moving their arms and legs or talking, and then we put them in there and now they're climbing out of bed, you have to be safe for that patient and maybe give them a little bit of sedative, not fully sedating because we don't want to lose our neuro exam either. CTAs, I know in our facility take about 5 to 7 minutes. So that patient has to lay very still for that time. Recommendation, just what is their neuro exam going back into that? Are they flaccid on the half of their body? We're going to need that CTA that would push for more, a little bit more sedation for that patient. A caveat too is neurospecialist might not need all of the images within the series, and they're super sharp at reading these. So maybe if you have a partial scan, sending that forward to see, do I need to sedate them before, or can you see what you need to see in the scans I got, even though they might be artifact driven because the patient's wiggly. So look at their exam before, and then possibly calling ahead and talking to that neuro professional, say, I have a plain head CT, it's negative for blood, patient is having a hard time. Should I sedate them for the CTAs or not? Depending on their exam, it might be different with every patient. So kind of a gray way of saying, look at the neuro exam and then using the least amount of sedation if possible.
Question came in asking, is there a checklist for stability?
And we actually, we don't have one. That's a really good actually opportunity. Maybe we should. We have, when EMS will bring our patients into Sanford, Sioux Falls, we would have them, the stroke best practice, that stroke alert's already happening. We know EMS is 3 minutes out. The ED doctor will actually walk with us from the EMS bay to the CT scanner, looking at the airway, looking at the pressure, getting report, and he can cancel that cancel straight to CT at that time if it's not a checklist, but that first assessment, they're not stable, go to the room first before we get stable. Good question.
What is the reason to do a CT first rather than a CTA?
CT is to rule out hemorrhage, and our in our protocols too, we do CTAs on every stroke regardless of how severe their symptoms are, looking for that large vessel. But a CT would rule out that hemorrhage. And I know a lot of facilities, maybe they are unable to do CTAs. So doing the CT would rule out hemorrhage first and then go on to do CTAs looking for large vessel occlusions. In hemorrhagic stroke, so CTAs would show a spot sign or a spot within the hemorrhagic stroke that's continuing to bleed, where that patient can further decompensate. So CTAs are actually recommended in a lot of the hemorrhagic strokes too, but plain head CT to rule out hemorrhage would be the starting point.
Would you delay the thrombolytic to do the CTA after CT, or would you?
We don't. We will actually start mixing it. So our protocol, the CTAs, or the CT is included in the CTAs. We don't delay. We'll start mixing after the plain head CT, which is the first sequence. When they see no blood on there, they'll start mixing the lytic to administer. And if the patient, maybe the patient's wiggly and taking longer, we will stop the CT sequences to go in and give the lytic. Getting that to that patient as quick as we can and as safe as we can.
Fantastic questions. Thank you. And great answers. All right. I could give you 24 minutes back. There are no further questions. We'll just wait a second here. Okay. Jessie, as always, thank you. It was fantastic.
Thank you.
Next Friday, so a week from this Friday, we'll complete our webinar series. Dr. Sandhu will come in and talk about ischemic stroke guidelines. So it's kind of a culmination of all of our stroke month stuff. So stay tuned for that. If you registered, the one registration will give you access to all of them. So we'll see you a week from Friday, and just have a wonderful rest of your week. A nice Memorial weekend. Thank you.